Um, I want to thank particularly Mid-Valley Healthcare advocates for providing this opportunity for us to speak together this evening. I will start by providing a general update on the Oregon Universal Health Plan Governance Board progress through its first 4 months. We'll follow that with a couple of personal observations about what I see are the major challenges ahead. Because no one can speak for the board except the full board, I need to clarify that I'm speaking to you as an individual.
Understood.
First, a little review of Oregon Senate Bill 1089, which was passed by the legislature in the short session last spring, signed by Governor Kotek last August. Senate Bill 1089 creates the Universal Health Plan Governance Board under the Department of Consumer and Business Services, or DCBS. Because SB 770 Universal Health Care Task Force, on which I also served previously, did not complete the financial and operational portions of developing a full plan. The governance board is directly charged with designing full financial plan, operational implementation plan. Finances will include use of existing government revenue and a new public revenue collection plan to replace current private premiums and out-of-pocket expenses. The operational implementation plan will include planning for creation of trust accounts within the state treasury, reserve accounts, creation of a public corporation, well as a full operations and transitions plan. Board members were appointed by the governor in January, confirmed by the Senate in February of this year. Executive Director Morgan Cowling was hired in late February. 2 additional board staff, Jennifer Donovan as Senior Policy Advisor, Katie DeLuca as Executive Assistant, were hired in April. These 3 who work for the governance board besides these 3, Senate Bill 1089 provides 2 full-time support staff positions under the Oregon Health Authority. Until those positions are filled in a month or so, OHA support is being provided by Laurel Swerdlow, Devlin Prince, both of whom had experience supporting the Universal Healthcare Task Force, which preceded the governance board. Here is the board membership and staff. Helen Belanca, Chair; Warren George, Vice Chair; Sunway Chi; Deborah Diaz; Amy Fellows; Michelle Glass; Bruce Goldberg; Cheryl Ramirez; Judy Richardson. The asterisks show the 3 of us who also served on the task force and who are now continuing on the governance board. The governance board has had 4 monthly board meetings, 6 work group meetings since April, all open to the public. The work group meetings are opportunities for board members to discuss specific topics, such as reviewing our values and principles, helping to develop the work plan, which will guide the board's work. Among the accomplishments so far, there is an extensive list of administrative and legal requirements for setting up a new executive board or a new board. Our executive director, Cowling, has been instrumental in getting all of these tasks completed. For basic foundation review, the board has spent much time reviewing the work of the preceding task force, reviewing the efforts of other states. Thanks to the work groups, values and principles, work plan development is largely complete, and I will go over those next. Values and principles work group boiled down to the ethical framework of our work into 4 overarching principles: maximize health, fair distribution of medical resources, minimize financial hardship on individuals and families due to healthcare costs, strive for a sense of community ownership in the design and governance of the universal healthcare system. Looking at these 4 principles a little closer, the work group chose a number of key sub-principles, some of which I will now mention. Maximizing health means providing individuals with the power to make well-informed decisions for themselves about their own best care and to be able to act on those decisions. Individual patient satisfaction may be the best measure of high-quality care. A fair distribution of medical resources is actually more complex than many people realize. For example, it is different to distribute medical effort equally across all patients, or should we be seeking equal medical outcomes across all patients, even though that may not be possible? Work group is recommending that communities themselves should have a major say in defining fairness. Minimizing financial hardship on individuals and families will require avoiding the likelihood of high-cost events, and when high-cost care is necessary, spreading out the cost more broadly across society. Community's sense of ownership and governance can only happen when the full community is extensively involved in helping to design and govern the system. Therefore, the governance boards tends to do a lot of community outreach. These overarching principles organize and build on the values and principles specified directly in SB 1089. Major accomplishments of the governance board in terms of complexity and detail has been the approval of a work plan, which will guide our work through 2026. At the highest level, there are 3 phases to the work plan: governance board foundation, proposal development, and preparation of the final report. We are within about a month or 2 of completing phase 1, the governance board foundation. We are already starting into phase 2. This diagram shows how these 3 phases will align with each other, beginning with the foundation, the proposal development, and finally the final report. 4 committees are designed into the work plan and were formed by the board officially at the July board meeting last week. The 4 committees are community engagement and communications, finance and revenue, plan design and expenditures, operations and transition. This diagram may be a little hard to read at a distance, but it shows how the work of the 4 committees will interact with each other throughout the proposal development work phase and into the final report phase. Those of you who followed the work of the task force may notice one change in the workflow. In the task force, the plan benefits were designed first, then an effort was made unsuccessfully to design a funding system to provide the benefits selected. I say unsuccessfully because the task force never arrived at a funding plan which it was willing to recommend. The governance board will instead begin with the Finance and Revenue Committee first arriving at a revenue plan budget. Then the Plan Design Committee will design the benefits to work within that budget. Here is further detail, which I will, instead of asking you to read all of this, I will explain it in the following slides. The Community Engagement and Communications Committee will be co-chaired by Michelle Glass and Amy Fellows. Board member Warren George will also serve on this committee. Committee deliverables may be summarized as community engagement plans for different targets, including industry, business, healthcare providers, and consumers, and messaging strategy and materials to inform the public about the board's work and conclusions. The Finance and Revenue Committee will be chaired by Warren George. with board member Cheryl Ramirez also on that committee. Major deliverables will be a unified financing strategy and an analysis of the economic impact of the financing plan on all Oregonians. These two deliverables may look simple, but the work will be significant when all factors of taxation, ERISA law, and the goal of public and business acceptance of the plan are taken into account. The Plan Design and Expenditures Committee will be chaired by Deborah Diaz, with board members Helen Belanca, Chunwei Chi, Cheryl Ramirez also on the committee. The deliverables of this committee will be the design of benefits, eligibility, provider reimbursement, cost containment strategies, along with financial modeling, actuarial analysis of plan options that will include all the expenditures and savings. Operations and transition work streams will be broken down into two separate committees eventually. The operations committee will start first and be chaired by Bruce Goldberg, with board members Judy Richardson and Warren George also on the committee. The deliverables include plan to create an independent public corporation, a design of an operations plan, including organizational structure, facilities, staffing, and informational technology needs, recommendations on the necessary statutory authorities, the plan to create a trust fund in the state treasury, and of course, creating guidance on obtaining federal waivers. The transition committee will not be formed until about a year from now, when more plan details are known and the expertise and scope can be better defined. The deliverables will include the transition timeline, steps needed for implementation, reports on the effect on other state programs, and steps needed for transition, and developing an implementation strategy, including the workforce challenges. And by that, it means taking the steps that we can to be sure that we have an adequate provider basis. The first major next steps is to recruit outside members to apply for the board committees. The task force had 20 total members. The governance board only has 9. When we have 4 committees, some of the board members need to serve on multiple committees. We're going to need some help from the public to create our task. So a few members of the public will be selected to work on each of the 4 current committees. Applications for the committees were opened on July 8th and were set to close this Sunday, July 28th. But at the meeting last Thursday, the board has extended the application deadline 2 weeks to August 12th, based on public interest. Not everyone who applies will be able to be placed on a committee, but it's hoped that all applicants will continue to participate through attending meetings and using the public input process. The second major step is compiling a list of data and expertise, which will be needed by each committee so that we can prepare contracts with outside consultants to meet the needs that we cannot do for ourselves. Finally, I will offer 2 personal observations about the challenges ahead. First, government by nature is designed to be reliable, but not always creatively nimble. Some state agencies may be reluctant to encourage new innovation, which could affect the status quo. Fortunately, the Department of Consumer and Business Services, upon which we are located, has a reputation as being an innovation incubator. The second challenge I'll speak about is about the human strategy surrounding universal care and how to transition what is often portrayed as a social justice movement into a prudent, rock-solid business startup plan that will not only convince 4.2 million Oregonians to go into partnership with each other to create this plan, but will also convince financiers to invest in the startup and contingency reserve funds, which will be required with the bond rating and solvency of the state on the line if the plan fails. The emphasis of the governance board on financial details may seem like a violation to some of the social movement, or may seem narrow in scope, but it is the part of the universal care in Oregon, which was not completed by the task force and needs to be the primary focus of the governance board. Making the transition from social movement to business plan will be the key to enacting universal care in Oregon, or for that matter, anywhere. So I thank you. I will pause here for welcome questions and open discussion.
Okay. Fritz, can we do our usual thing with you checking for questions online and me checking with people in the room?
That works great. So everybody who's online, if you've got a question, go ahead and raise your Zoom hand, and I will call on you in order when Mark lets me know we're doing the online folks. And when it's your turn, I'll tell you to turn off your mic and ask your question.
Okay. Do we have anybody in the room who, yes, go ahead.
Announce yourself, Roger.
Yes, Roger Blaine, I'm a visitor. Warren, and part of your presentation, you talked about a public corporation. Can you tell me what, or help me understand what the purpose of a public corporation in this sense is?
Yes, thank you, Roger, and good to hear from you. In this sense, it's really kind of somewhere between government and private business, but the model would be something like the Oregon State Accident Insurance Fund, which is a publicly held corporation. So that's the basic model. And that is, that's preliminary. All the guidance that we have so far says that would be the right kind of structure, not to be beholden too much to the legislature, but still publicly controlled.
Thank you.
Okay. We'll do one more in the room, Linda, and then we'll go online.
Announce yourself.
Hi, Warren, this is Linda. How many members of the public or non-board members are expected to be selected for the various committees?
Thanks, Linda. We don't have a magic number. The numbers that have been batted around are maybe that we would add 4 to 10, but that's not hard and fast numbers. Speaking for my role on the finance and revenue, we're looking for, I think, a few key economists and people with extensive knowledge in the finance and revenue portion, and we may be looking for smaller numbers than, say, for instance, the communications committee, which might be looking for more like 10 people to help out with that task. I hope that's helpful.
Yes, thank you.
Okay, Fritz, your turn.
Karen Christensen, you are the first one to put your hand up. Please take yourself off of mute and ask your question.
Thanks, Fritz. Warren, thank you so much for the work that you're doing. How would you suggest that people help with the task of communicating to the governance board the importance of having a solid business plan, so that this is a very pragmatic but understandable system that is created?
You said it very well, Karen. Thank you. That would be very helpful to the things that I believe that we need to accomplish, to keep reminding the board that this task is a financial task, and that when we get done, there'll be a lot of social problems that still exist. We're taking on one. And if we try to spread ourselves out in too many directions, we won't be able to achieve that. So I think it would be a real helpful in terms of emails or public comment, letters, or actually appearing in person or online at board meetings, and encouraging focus on getting the business plan done. I think would be helpful. Thank you, Karen.
Thanks, Warren.
We'll go with another one from online, if that's all right. Next
Yes.
person with their hand up was Rich Shannon.
Hi, Warren.
Hi, Rich.
It's always great to hear from you. How much of what is currently envisioned in the Oregon plan will require some or all of what's in Ro Khanna's bill? Are you stuck if that does not get passed?
That is an excellent question. And of course, we're following that closely. I've made that statement before that if we can't get everything into one basket, the benefits of achieving one single reimbursement rate and being able to go straight to global budgets on hospitals and things will be in jeopardy. But I don't think it's a lost cause. I don't think it's a lost cause if SBUCA doesn't pass. What we're thinking and what came up in a board meeting is we think our timing might be about right. We're presenting our recommendations to the governor and the legislature in the fall of 2026 for implementation, at least a couple of years after that. So I think that SBUCA has a chance to pick up steam and hopefully to pass. But there are some little tricks that are maybe a little harder to do that would get around that problem. And if you ask, I'll suggest one or two of those. Please ask.
We asked, we want to know.
Yeah.
Well, you can think in terms of, if you want one system, it doesn't have to be, it doesn't have to all flow through the exact same clearinghouse, as long as multiple clearinghouses play by the same rules. So an example of that, if we could design a plan that looked, and I'm going out on a limb here, but just to demonstrate, if we could design a plan that looked exactly like a Medicare direct contracting entity, we could actually have the state accept responsibility as a direct contracting entity for Medicare, but not actually have the funds flow into the state single payer system. But still, as long as everyone was playing by the same rules, to the extent that hospitals and other providers wouldn't really know the difference or care, because the rules are all the same. So that's, my first choice is certainly to have have everything flowing through one clearinghouse, and for a lot of payments to be under global budgets instead of fee for service, or certainly very simplified fee for service. But I don't want people to get discouraged if that looks like a long shot.
Thank you.
Thanks, Rich. Good to see you.
How about Keith?
Warren, thanks for all your work as usual. My question is, what factors led the board to adopt a revenue/finance first approach rather than an access to care services first approach?
Well, I think, sometimes when you're stuck, you go backwards and then you go forwards to try to get out of the rut. And I think there was fear that on the task force that the benefits were maybe more generous than people were willing to put into one package, or maybe there just wasn't time. And so there was thought here that if we actually work it backwards, that we might get further faster. Whether that's true or not, time will tell. But I think no matter what we do, it's going to be a little bit of an iterative process. Well, I don't know. How much revenue do you want? Well, I don't know. How many benefits do you want? And so you end up kind of having to match those two iteratively. And I suspect even though they've designed it to be revenue first, then benefits, I expect it's going to be iterative, going back and forth between the two, trying to find some sort of sweet spot that matches. And this is a key to me, I think, is understanding public and designing a system that the public will support. I think is actually key. So thank you, Keith. I hope that answers the question. Is well, we don't know. We're going to try it out.
Let's see, do we have any other questions in the room here? Maybe not. Have you got any more questions online?
Well, we do have one that was put in the chat from Hank in Maine. Hank, I assume since you put it in the chat, you'd like me to read it. If not, go ahead and take yourself off of mute.
Sure, I'll so just wondering what your budget is. In other words, how much money do you have through 2026 for all of the different governance board activities?
The answer is about $2 million for our 5 staff, and somewhere between 500,000 and 700,000 in consulting. And the legislature is going to meet again before the end of that. And if we can find, we're hoping through the legislature, we may find a little bit more money if we can demonstrate that it will be useful and necessary for the cause. So, that's a ballpark. And that can change a little bit just by budgetary years. The fact that we got a little bit of a late start. I mean, seems like you never get started ahead of time. But since we started in the middle of the fiscal year, more or less, there'll be some pressure to get some money spent earlier, so as not to lose it.
Thanks.
Great. We do have a couple of more hands up online. Rich, I see you had yours up, but since you've already asked one, I'm going to go to Susan Malero first, and then we'll go to you, Rich, if that's okay. So Susan, go ahead and take yourself off mute, ask your question.
Hi, Ross. Long time no see.
Hi,
Um,
Susan.
how can you reach people with disabilities to be part of this plan?
Okay, if I understood all of that, we're working hard to make sure that all populations, including differently abled populations, are served, that they get their fair distribution of medical resources, and that nothing stand in the way of that. That's for both people who are disabled populations on Medicare, as well as Medicaid and through other means. I know that you'll be watching us and making sure that we do it right. So I thank you, Susan.
We missed you on the legislative committee. I wish you come back.
All right.
Great. Rich, why don't you go ahead and take yourself off mute?
Sure. Warren, one more. I'll start with the assumption is that whatever is put together as will go to a public vote. And if that's correct, I have a specific question. Or is it possible the legislation could be just done by the legislature?
The legislation, Senate Bill 1089, presumes that the legislature could pass and implement that. I think you and I and everybody else in the room knows that the legislature probably isn't going to do that unless we can design it in a very specific way, starting very gradually or something. So yeah, I think we have to make some assumptions that it's likely that the voters would vote on this. So go ahead and ask your question.
It's based on our experience in Colorado in 2016. You and I think, have had this discussion before too, that people who are on Medicaid can very easily be scared. The opposition can show how they will get screwed, things will get worse for a population that now feels they've got a stable, more or less medical program that's working for them. Have you had any discussions, or does the bill allow you to look at a state-based system that's for people under age 65, with the state becoming a Medicare Advantage plan, so that you can tell seniors nothing will change unless you want to change?
Yeah, there was a couple of items there. One is, I mean, we in the task force, which I was on, considered the idea actually fairly favorably of having a state Medicare Advantage program in order to bring people in voluntarily. I was one who was very concerned about doing that because whenever a public program competes with private programs, the adverse selection gets out of hand in a hurry. And so you would have to almost figure on putting extra money to sweeten the pot. So you'd almost have to raise the tax to subsidize a state-based Medicare Advantage program to have it compete. So yes, there's a lot of sentiment toward that. Whenever I hear it, I speak against it because I don't think it would. I think that the private Medicare Advantage insurers would cherry pick and leave the high cost to the state and run the state plan out of business. There was another part of your question earlier. Could you repeat that?
Given what you've said about Medicare Advantage, then how about the merits of just creating a system for people under age 65 in Oregon, so you're not dealing with the fear factor with seniors?
Yes, and you'll recall that along with fellow businessman Ron Lowe of Corvallis in 2019, I commissioned a poll of Oregon voters, which showed going through a problem solving sort of step that we could convince 62% of the voters to support a reasonably high tax in order to have universal health care for everyone. There's two things to say about. One is just because we can talk somebody into something, wait and see when someone else tries to talk them out of it. So the bigger the change, the more it is, the more time and the more time there are other interests who can talk people out of things. Certainly, if you are going to tell 4.2 million Oregonians that they're going to go to sleep on December 31st and wake up on January 1st under a complete new system, the rate of change is incredible, and the factors of fear are going to be easily exploitable. So you look what other ways that you could bring about change more gradually, and using things like Social Security as a model. Social Security started out with a 1% tax, and it took 30 years to build up to the level that it is now. And Medicare, the same, started with very low taxes. So looking at rates of changes, I think, is key to getting public success. But you hit on something else that I think is really key. And one of the ways that you could implement something, for instance, is by age. So something that I've looked at before is the idea that you can start with, say, everyone born after 2000, or pick a date, 2005 or something. So you're getting the people who are lower cost. They only cost 1/6 to 1/10 the average healthcare needs of people in the older brackets. Can you start a new system with them, which retains the low cost as they go? And in the poll where voters under 35 were supporting universal care by over 70, close to 80%. So that's the population that is most interested. And if you could design a program that really focuses on their needs, you're going to find an easier time passing it. Another idea toward kind of a gradual approach that I've proposed on a couple of occasions, and also have heard proposed by some hospital administrators, is, instead of trying to do everything at once, start with some of the things that cause the most fear and most bankruptcies. So for instance, if you had a small tax, but maybe a 3% tax that covered all oncology, put it immediately under a single payer system, that might be a gradual way to approach. The country of Chile actually has done this, starting with a limited number of diagnoses and gradually expanding it as people get used to the idea and are encouraging it. So that was a long answer, Rich, but it was a long question.
Thank you.
I see one more hand, Linda.
Lydia and Bruce one.
Lydia?
Yeah, it was Lydia. You're on mute, Lydia.
Thank you. Hi, Warren. I just
Hi.
have a couple of things I need clarification on. In the financing, are you excluding the VA and the Indian healthcare?
Hi, Lydia.
Hi.
Good to see you. And the task force, the governance board, has not actually made a decision on this, but the task force kind of drew a line that said, if there's already a budget for it and it's not open to the general public, it would not be included in the state single payer system. So the fact that there's a budget for veterans, the veterans facilities are not open to the general public. Our assumption was that veterans would actually want to keep their own providers that they've been working for, and we would not want to not want to get in the way of that, not want to disturb it, and but also the fact that they are any resident of Oregon would be able to seek local care. That there might be some care that used to be provided by the veterans that would be provided by local healthcare providers under the single payer system. So along with many of you here, we've tried to make the writers of SBUCA and the sponsors aware that not only would we want Medicare money and Medicaid, federal Medicaid money, we'd also want some way to monitor people who are currently federally cared for through the VA, through IHS, and through similar federal programs that the state would want to be reimbursed for that. So that would be important to us as to have as part of the state or part of the state-based Universal Health Care Act. But I might also mention, besides the VA and IHS, there are some other organizations that I think also would be exempted from the single payer system. They include state mental hospital, not open to the public, and also prisons. But another thing, it'd be, some universities have infirmaries that are supported by student fees. And it wouldn't, we would foresee that kind of thing happening. And also, you consider things like employers who provide nurses or doctors at some remote location to serve people who, because there's no local care, we would want those kinds of things continuing. Students on research vessels out at sea, or that would be silly to run that through this state single payer base.
Yeah,
Thanks,
and you
Lydia.
anticipated my question about Medicare and Medicaid. Thank you for answering that. And do you think that if a Medicare Advantage plan was considered, that it would alienate PNHP doctors and other people who are fighting very hard against Medicare Advantage?
Yeah,
Some of us are too.
Yes, and me too. And my reasons for being opposed to state operating or offering Medicare Advantage in competition with private insurers is just because I don't think the state can win at that game, and will end up losing big. The public options, there aren't any successful examples, just because, there's multiple reasons. One is you don't get many people to sign up. The savings of public insurance companies is not great enough to make a difference. And of course, the third thing is when you consider that 20% of the population, well, let me put it this way: the upper 20% cost 44,000 a year, and the lower 80% cost about a tenth to a 40th of that. Any small shift in the who has the sicker patients. I mean, and some people believe in risk adjustment. For me, risk adjustment is so often game that I wonder if it can be fixed. But you get the point that the private insurance companies will cherry pick the cheapest customers in a way that the public Advantage plan in this case just wouldn't be willing to do. I mean, it's just not in our DNA to try to kick the healthy people off. That would violate our sense of duty here. So I know that's a little bit oblique to your question, but okay.
Thank
We
you.
have time. We have time for one or two more questions. I think there's somebody else online.
Yeah, Alex, why don't you go ahead and take yourself off of mute? Ask your question.
Thanks, Fritz. Hey, Warren, thanks so much, as usual, for your exemplary work in this area. My question is along again on the Medicare question. So since speaking of shifting risk, I mean, obviously the Medicare population, is, I think you already mentioned, is a much greater consumer of our healthcare dollars. And being one, I can speak personally about that, than those younger. So it makes sense as far as it would make sense as far as a gradual shift, especially since, well, I can speak for myself. As an older person, you usually want less change. Change is scarier as you get older. So it would make sense that way to, especially since getting a waiver for Medicare, the Medicare population, a federal waiver, is the highest bar of all the waivers that would be required, is my understanding. You can correct me if I'm wrong. So it seems like, it seems like as far as that went, I mean, that would be kind of the least, if we're not going to get everything into a one pot, that would be the course of least resistance anyway, if we had to exclude a population, that it would be Medicare if we couldn't get a SABUCA waiver. So that's my first question. And the second one is, there's already been talk about, Medicare Advantage, and I understand your argument about not competing against private. How would being a direct contract entity, or DCE, figure into that? And would that necessarily, how would that work as far as the state financing and administration? And would that necessarily avoid all the intricacies of having to get a waiver? Thanks.
Oh, good to see you, Alex. Yeah, well, okay, let's see what I can get out of that. And there's some more intricacies that you bring into that. But certainly there are advantages to figuring out how to keep Medicare separate. You could provide what a lot of people call a wraparound, so that for people on Medicare, they would still be on Medicare, but they'd get new state single payer benefits that would more or less match supplemental plan, dental, optical, hearing, and things that are not covered or well covered. One of the things that occurs to me to mention is that the waivers, and you talk about the difficulties of a Medicare waiver. Well, the kind of waivers that Medicare has granted has been like a 5-year waiver. Well, can the state live with a 5-year waiver when when we're building a 50-year plan here. And what happens if the state loses its waiver after 5 years? One of the things that, speaking from the fiduciary concerns of the state, you don't want to be in a situation where you suddenly become liable for all the Medicare population because the federal government is not paying for it or something. So your concerns resonate with me, and I think senior population is key, if for no other reasons that they vote at extraordinary percentages. And something that the task force never did that I thought was imperative is you really have to separate out the seniors as a separate population and recognize that they're already getting care that's based on premiums and payroll taxes that pays for some of that cost. And so you really need to design the system that may be slightly different for seniors and is targeted both in terms of revenue collection. You want the benefits to match any revenue that you take from them. And you want them to feel like they're getting a fair shake and not worried about losing anything. So that answers part of your question. I might have missed another piece in there that was at the beginning, if you wouldn't mind repeating.
Yeah, well, the second part of it was just how that DCE would operate on a state level, and how, and would that really avoid all the the issues that come up with, like you say, directly competing with insurers in the private market.
Well, the DCEs are direct contracting entities, and now it might be called REACH or something like that, is different than Medicare Advantage in that it's the pilot innovation programs that are doing this. Everybody who is in a geographical area is moved on to for lack of a better word, a private insurance company that takes on the risk, gets paid a per capita amount, and then can arrange whatever deal they want with providers. So, and people don't have a choice. There are people on DCEs that never signed up for them, but their whole area has been taken over by this contracting entity. Well, why can't the state be that contracting entity? And it would actually enable Medicare to pay a per capita amount, which could more or less go straight into global budgets for hospitals and major clinics. So I think there's some possibilities there that really aren't very researched, but I see some possibility to look in that direction.
So you can get your staff to look into it then, right?
Yes. Yeah, we'll see.
Thanks.
Okay. Thank you. I think we better wrap it up. I don't know, Warren, if you have any final words for us, or any last message you'd like to give before we move on with the meeting.
Well, we knew from the beginning that this wasn't going to be easy. I think all of us kind of understand that. But I think, particularly here in Oregon, we're in a position to maybe make a change. We've never seen as much interest as some business people in hospitals and providers, particularly in Oregon, with 60% of hospitals losing money through the first half of the year. Providers are very interested in finding stability, and I mean, hospitals and the like. So I think, you know, the environment is growing more favorable. You know, some of the things that we need to overcome are actually in ourselves. It came up earlier with people saying, gee, if everybody gets health care, you know, I might have to wait another week. That's not fair. Well, you know, we have to listen to ourselves when we think that way, because we have to overcome that. So a lot of obstacles, both outside of us and a few inside of us, that we need to look at this not as a way to win something, but as a way that through group sacrifice, we can arrive at something far better than we have now. So very good to see everyone. I really appreciate, and particularly all the people who had to stay up late.
Well, thank you. Let's give Warren a hand.